In pediatric cardiology, an echocardiogram is the definitive tool for diagnosing dextrotransposition of great arteries, known in short as DTGA. For a clinician, the essentials involve more than just seeing the switched vessels. You must meticulously detail the coronary anatomy and mixing sites to guide the surgeon. In the subcostal or apical view, look for great vessels that run parallel than crossing at 90 degrees angle, which is normal. And in the parasternal short axis, you look for the double circle. In a normal heart, you can see a circle and sausage with aortic valve in cross section and the pulmonary valve, or rather right ventricular outflow tract, wrapping around it. In DTGA, you see two side-by-side circles because both vessels are viewed in cross-section simultaneously. Confirm ventriculoarterial discordance. In subcostal view, identify the morphological left ventricle. Morphological left ventricle has two papillary muscles, while right ventricle will have three papillary muscles, and the valve will be bileaflet, mitral valve for left ventricle and trileaflet tricuspid valve for the right ventricle. And tricuspid valve is more proximal. Then follow the outflow of the morphological left ventricle. In DTGA, LV gives rise to pulmonary artery, which is identified by its early bifurcation into left and right branches, that is RPA and LPA. In case of aorta, it will arch and give rise to multiple branches. The baby's survival depends on shunting. Look at the atrial septum in subcostal view. Assess patent foramen ovale or atrial septal defect. Measure the size and use color or spectral Doppler to determine if it is restrictive. Restrictive means small ASD or PFO with a high gradient. A restrictive ASD with severe cyanosis is an indication for an urgent balloon atrial septostomy for enlargement of the mixing site. You can look for ductus arteriosus or patent ductus arteriosus in the suprasternal notch. In DTGA, blood typically flows from the aorta to pulmonary artery via the ductus to provide oxygenated blood to the lungs. Coronary artery mapping is crucial for surgery. This is the most technically demanding part of the examination, typically done in parasternal short axis view. The surgeon needs to know the origin and course of the coronaries to replant them during arterial switch operation, the most important corrective surgery for transposition of great arteries, also known as Jertny procedure. Identify two facing sinuses, the sinuses of aorta that face the pulmonary artery. Standard anatomy is the left main arising from sinus 1 and right coronary from sinus 2. An associated ventricular septal defect may be found in half of the cases. Check for subpulmonary stenosis. A high pressure left ventricle due to subpulmonary stenosis can actually be beneficial for training the left ventricle before surgery. Even a bit delayed surgery can be useful when there is subpulmonary stenosis. Otherwise, early surgery within 2 to 3 weeks of life is needed to prevent regression of left ventricular musculature as it faces the low pressure pulmonary circulation after birth. To summarize, in the subcostal view, confirm parallel vessels, measure ASD PFO size. Parasternal long axis view, visualize pulmonary artery arising from LV, assess mitral pulmonary continuity. Parasternal short axis view, the gold standard for coronary origins and vessel relationship. Suprasternal notch view assess the aortic arch and PDA status.